Good morning, everyone. My name is Adam I'm one of the PGY3 residents for the people who do not know me. And I'm going to be giving the ground talk today about lit. Title is All Things Lit. Um, no disclosures. What's lit? So lit is an acronym for laser interstitial thermal therapy or laser induced thermal therapy. And laser is actually an acronym that originated from the acronym light amplification by stimulated emission of radiation. And that what that means, for people who remember physics lessons, what is a laser? So basically, a laser is just a lasing medium enclosed between two mirrors, which one of is partially transmitting to light. And then when you apply an energy, any sort of energy to a lasing medium, more atoms of that medium will attain an excited state, and then a photon is going to strike the atom, and then it's going to fall to the photon is going to fall to the lower energy state. And in this process is becoming stimulated emission, and the coherence of this laser light allows it to be focused in an intense beam that can be used in different applications. Um, so my outline for the talk today, I'm going to give some historical perspectives on lit and lasers in neurosurgery, mechanisms of lit, technical considerations, clinical applications, and the complications and safety profile of lit. So starting with a historical perspective, so the first operational Ruby laser was designed by Mayman in Hughes lab, which was also part of the aircraft industry at that time. Then in 1964, the first CO2 laser was designed. And then in 1966, Dr. Razumov, which we all know was one of our past chairs, used the first Ruby laser on human gliomas. Followed by that in 1969, Dr. Steller used the CO2 laser on a GBM. Between the 70s, 80s, there's a large series of laser being used in neurosurgery. And then the first American Congress actually conducted their talk on the lasers in 1981. So this was the first laser design, and as you can see here, how huge it is, and which will take us to how it's becoming more designed to be more easy to use, smaller designs, and so forth, which I'll be talking about today. So the Ruby laser that I just mentioned in 1960, this is the laser device as you see on the left, and this is when they start applying it to tissue cultures. And you can see here, this is a malignant tissue, and then after they laced it, and then you can see how the malignant cells become damaged. Now they start applying lasers to actual brains, and then you can see here that this is the first time they start applying it to animals. And you can see on the left, this is a cat. They gave the laser while the brain was enclosed in the head, and then you can see the bioccipital contusions and hemorrhage. This is another image of the laser now applied to the actually exposed brain, and you can see the subarachnoid hemorrhage. Moving forward, this is also applying it to different mice, and you can see how the laser impacts it, causing contusions, hemorrhages, and another one on melanoma, and so forth. Now, in 1964, CO2 laser becomes designed now, and they also start using it on animals. And you can see here on the left, this is also a brain of a cat, and you can see here how there's no hemorrhage or on the brain. And on the right here, you can see this is the actual CO2 laser. You can see on the right the laser, and then on the left, you can see the laser actually connected to the microscope, and you can see the foot pedal that they're going to be used to operate the laser. And now applying the CO2 laser as well on animals, you can see here a mouse with an ependoblastoma, and then after lacing it, there's no residual tumor. So as I mentioned, Dr. Razumov, who we're all familiar with as a past chair, he actually was one of the first people to use it on human. So in 1966, he mentioned in a JAMA article the reaction of neoplasm membrane to laser. And in this article, he actually had two patients where he that had a non-resectable brain lesions that he decided to, with the family agreements and so on, to use the laser. The outcomes were not good. So within a month from using the laser, the patients had died. And then in 1969, also, Dr. Steller started using the CO2 laser for the first time to resect the GBM. Also, the outcomes were not fairly good. moving on. So as I mentioned now, after 1969, there's a large series out there in the 70s, 80s with using lasers on human. But the main thing that we're gonna talk about is how that changed to today. Why is there a boom or an emphasized use of lasers? So in the 90s, there's now an international emphasis on laser, using of laser. So we see here, this is the first paper that comes out of Japan where they used it on 5 patients with laser hyperthermia. And interestingly, when laser started being developed here as well as in Austria, it was actually not called LIT. It was called ITT, interstitial thermal therapy. And then you can see across the nation, across the world, different countries are starting to use it. Not as much in the US yet, but you can see that the YAG lasers are being used. You can see here now another article coming out of Paris with the ITT and so forth. They're all like case series, very small case series, actually, or case reports, I would say. Same here now, the MRI starts to be coming into the picture, and now using the MRI is what is going to move the field a little bit forward. So this is a review, and now the MRI actually, the way it's being used is how it's going to be able to measure the temperature and guide us to understand how much the temperature has changed with those lasers. So the MRI thermometry and the proton response frequency method protocol that was designed in Belgium helped us to move forward with that. Going on, so as we can see here, LIT and introduction neurosurgery. Over the time, as I mentioned, now we have the MRI being introduced into the picture from 1996 and now up to 2024. And you can see how there's an exponential increase in the literature on the topic. As of now, there's 408 published papers on LIT and neurosurgery. And shout out to our neurosurgery department, because out of those 408, actually 25 articles come out of University of Miami. And those 25 articles, like that, this is like almost 6 or 7% of the literature on LIT. Looking into the clinical trials that are going on in LIT. So as of today, there's actually 40 clinical trials that have been conducted or are being conducted on LIT, including 32 clinical trials running for on the use of LIT in neurosurgery, sorry. So we're going to be going over the indications and everything in particular as I move forward, but this is just the general view. One of those actual upcoming trials is going to be run here by Dr. Shawnee's team, known as the Starlight, where they're going to also be using the LIT and introducing the antiretrovirals and studying that as well. So I want to talk about now the mechanism of LIT. What makes LIT useful, or how do we actually target brain lesions or using LIT? So the laser actually works in 4 different mechanisms. So there's the photothermal effect, which is the basis for LIT, which is the light being converted into heat in the tissue. But also there's the photochemical effect, and this is the interaction between the laser light and the tissue having the photosensitizing agent, leading to the phototoxic reaction in the tissue. And there's the photomechanical effect, which is the short laser pulses leading to shock waves. And the last is the photoablative effect. And then this is the the cell molecules being broken down, the bonds actually being broken down. There's also the secondary mechanisms that come with LIT. So changing the temperature on the cells and tissue, whether it's being hyperthermic and also coagulating it, occurs. And then depending on the thermal dose that you apply, so either the cell would be dead instantaneously, or it actually will die over a few hours, between 24 to 72 hours. But one of the mechanisms that we're going to be talking about in LIT is actually opening the blood-brain barrier. And this helps in understanding how this affects the chemotherapy being delivered and the immune modulation that's happening there. So all these different mechanisms make us understand why we're pushing the field forward to using the LIT. And as I'm going to be presenting some examples, understanding that the ablation of the tumor is not always in um, the direction of the probe, but also it depends on the target tissue itself. Because the tissue, they end up encasing some of this energy, not rather than dispersing it. So I want to give this is a cut on one of the brain tissues that actually received lit, and you can see here on the left, this is acute effect. You can see that A, this is the central laser probe defect. You can see in B, this is the coagulation necrosis that happens, and then the perifocal edema around that, and then the normal tissue. Uh, and then in 1 week afterwards, when we look at this tissue, that you can see the central zone being necrosed. You can see the transitional zone of mesenchymal cells, and you can see adjacent to that the undamaged tissue. So I want to give also now a brief explanation of how do we use lit? What does that entail? What's the workflow looking like for using lit? So this is a common workflow step that includes different aspects. So first, when the patient is in the OR, we start by the trajectory planning using our neuronavigation system, and then afterwards we go ahead and drill the hole in the skull, attaching the fixation system. And I'm going to give detailed explanation of each of those steps. But in general, once we're done with the OR part, then we go to the MRI. After inserting the laser. Some institutions also actually insert the laser in the MRI, and then you acquire MRI imaging to be able to know where the laser is. And then once you identify that the laser is in the correct place, and you have your parameters of the temperature, the acquisition, and what you want to be your threshold, then you start giving the ablation and firing the laser, basically. We'll talk about each of those steps, but this is the common workflow that I want everyone to have in mind. So this is how the lit station looks once the patient is in the MRI. So you can see here on the left-hand side, patient is in the MRI. You can see the laser probe coming out of his brain. And this is one of the two devices that are currently in the US, which is the Monteris. The Monteris uses also a CO2 workstation that's outside of the MRI. And then you can see as the person managing the laser has the MRI working station and the control working station that for the laser. So I want to break the procedure into 3 different parts. So first, choosing the laser type that we're going to use, the trajectory and the number of lasers, and then the laser fiber insertion itself, and then the laser ablation. So choosing the laser type, as I mentioned briefly, there's 2 types of lasers. There's the Medtronic Visualase laser, which we have been heavily using at University of Miami. And this is a picture of it. And you can see here, this is the laser exit, and it has either a 3mm diffusing tip or a 10mm diffusing tip. And this is the bone anchor that we're going to be using. And you can see here the laser cooling catheter and the saline that's going into the cooling catheter. And this is the Monteris NeuroAblate. And we have been fortunate enough to do our first case using the Monteris a couple of weeks ago. So the Monteris has 2 different laser probes. So it has the side fire and the full fire. And this is where the laser fiber would exit. And then this is the temperature sensor, and this is the CO2 cooling tube. As I mentioned, given that there's a CO2 cooling device outside. So on top is the Visualase, and on the bottom, the NeuroAblate. You can see here the bolt being placed in the Visualase system and the NeuroAblate. And I want you to compare the difference. You can see here how the different sizes, you can see the different calibers, and you can see here that the NeuroAblate system being a little bit more complex when it comes to the external part of the laser. So this is how the patient is sitting in the MRI when they have the Visualase. And you can see the bolt being inserted, and titanium bone anchor, and the cooling system and the saline running to the outside of the MRI. And this is the NeuroAblate. As I mentioned, so the NeuroAblate, the patient is in the scanner, the patient has his head fixated, and then there's the probe driver. And they also have what they call a robotically controlled probe driver. So this motor, actually, its function is to being able to change the pull and on the laser device inside the brain, and also changing it when you have a side fire device. You should be able to change your trajectory while the laser is being there, which is a different mechanism that's not in the visual ace. And this is the interface of the visual ace. So this is what you see outside of the MRI while you're sitting there. And there's different screens, as you can see here. So we have two different cuts on our screen that we'd be looking at. There are different targets that you assign on the brain tissue. So you have the higher threshold and the lower threshold temperature. Basically, your lower threshold temperature are parts that you're trying to protect. You're making sure that the temperature does not go over a certain number to ablate it. So as we know, the brain temperature is 37 degrees, similar to body temperature, between 37 to 40 in some cases. As once the temperature reaches 43, this is when you start actually having effect on the brain tissue. So you place your lower threshold temperature, your high threshold temperature around the actual laser probe to make sure that your laser does not get burnt in there. So this is also the neuroablate system. The one thing that I mentioned that's important, as you can see here on the right side, on that little bottom, you can actually move the side fire directionality and change where the laser is coming out from. So this is a comparison between the neuroablate, the Monteris, and the Visual Ace Medtronic, and those are the only two systems that are FDA approved in the US since 2008. One things that I would like to highlight, I already mentioned the side fire and the neuroablate, but also the diameter. So you can see here the Visual Ace has a much smaller diameter. It's 1.65, and I think some people feel more comfortable when the diameter is actually this small and compared to 2.2 and 3.3, meaning your drill and the Visual Ace is only like you need a 3.2 drill, while on the neuroablate you're going to need a 4.5. We talked about the difference in cooling between the gas cooling, the CO2 cooling, and then the circulating sterile saline. And in general, I think multiple institutions only have one of both devices. Not a lot of institutions have both devices. We here now at University of Miami have both. So I think in the upcoming years, we'll be able to also compare to see if there's any difference in the outcomes. So the laser trajectory general principles that we have. So after we chose our lasers, now the trajectory that we need to choose. So there are general principle rules that we keep in mind, making sure that we avoid the highly vascular Alcorn brain areas. So we obtain an MRI with contrast before that helps us. But sometimes in some patients, when we're not able to get those MRI with contrast, a general theme is making sure that you go over a gyrus versus rather than a sulcus, because that minimizes your risk of intracerebral hemorrhage and going through vasculature. Some other principles that I want to mention, and this is based on our experiences and other institutions as well, that your target diameter may require multiple trajectories, and we'll show some examples for this. And then the laser as well, it could be pulled back to create like a column of ablation. Another thing to keep in mind, most of our LIT patients get biopsies before that. So you need to understand how the biopsy target length is going to be different than the actual LIT length, making sure that your biopsy needle is going to actually reach where your laser is going to be. Additionally, we want to make sure that people understand as well, when you have multiple core biopsies, that would introduce air and blood, and that is going to affect the ability of the thermal information that we get through the MRI. Other things that we also want to keep in mind are heat sinks. Heat sinks are basically fluid spaces, large CSF spaces, larger blood vessels that change the laser tip diffusion less predictably. Our medical students here, Shovan Bhatia and Chandler Burke, have been actually working on being able to quantify what's the measurements that we need to consider heat sinks, and I believe their paper is coming out soon in the Red Journal, so that would be also an addition to the literature. Placement of the fiber trajectory. We as I mentioned, we need to understand that those heat sinks might affect our ablation, so we need to understand how to place it based on those based on this information. Once we have our trajectory defined, now it comes to the laser fiber insertion. So there's two categories of how you insert the laser. There's the frame base and the frameless. Luckily, also University of Miami, we have both, and as residents, we get to practice both. So we practice the traditional stereotactic framing, which is the Lexel, the CRW, and then we also use the frameless, whether it's the ROSA, robo-guided, or the Medtronic, the Vertec, and the PDA. So this is the traditional stereotactic frame that people are familiar with. This is Lexel frame. This is CRW. This is the Stealth, the Vertec arm, and the precision aiming device, and the ROSA robot. Once we have it in place, then we start our laser ablation that we're going to be talking about. And you can see here. So basically, this is the zone of the ablation, and this is the based on the mathematical equations, and this is what the laser mathematical methods defines as being ablated, and this is what the temperatures that are captured on the MRI thermometry. And this is the same thing, but on the Monteris device. So moving forward to the clinical applications. So I want to talk about the use of LIT in different clinical scenarios. So I want to start first by giving the position statement that came out from the AANS and the CNS on using LIT in neurosurgery and basically for brain tumors and radiation necrosis. So the indications for LIT now being defined by AANS and CNS, that LIT is already, as I mentioned, is an FDA approved device since 2008, and it's used to be ablate, necrotize, and coagulate the intracranial soft tissue, whether being in brain tumors, radiation necrosis, and eleptogenic foci through the irradiation of the thermal therapy. And they base this the recommendations of AANS based on multiple factors. So there's now numerous peer-reviewed publications that demonstrate the safety and efficacy of LIT, as I mentioned, almost 400 as of now. And then the procedure recovery, the short length of stay, the wound healing, patient being able to receive adjuvant treatments, as well as the NCCN now adding LIT as part of the treatment paradigms for brain tumors. And there's consensus as well now that LIT can be used for patients that are not cleared or inaccessible for surgical resection, or patient with multiple comorbidities, and being performed by highly trained neurosurgeons as well. We can see that the outcomes have been great. So the efficacy of LIT. So as of today, the LIT has been used in over 8,000 procedures, and this is almost in 150 sites over the US. So there's over 2,000 patients that have received LIT. And the literature showed that the safety, effectivity of the LIT. The benefits of LIT that have been published upon, so low morbidity, faster recovery time, decreased wound time healing, hospital intensive and ICU stay, being able to access lesions that are not usually accessible by surgery, hospital length stay, and then the overall survival being improved on patients with non-resectable tumors. So I'm gonna give some examples. So first, LIT in glioma patients. So as of now, this is some of the literature, not all the literature, of the using of LIT in the glioma patients in a systematic review. So this is one of the cases for a 41-year-old gentleman. As we can see here, he has a left frontal GBM that underwent laser and ablation and started on chemotherapy. And you can see here, but in a 1 year after and a 2-year follow-up where the tumor is almost gone. Now he's 7 years out and his tumor is completely cured. This is another case that we also had here recently at UMH. This is a 58-year-old female that went to an outside hospital. So they went ahead and performed a biopsy, and then they referred her to our teams here for the neuro-oncologist to be able to start on clinical trials and neoadjuvant chemotherapy. Our radiation oncologists knowing now about LIT and understanding the potentiation, how LIT can help with the cytoreduction and also help with the adjuvant chemoradiation and opening the blood-brain barriers, they actually referred her to us. So she underwent LIT and biopsy this week, and their plan is to start on chemotherapy and radiation within the next a week or two. And this has been published by the group at University of Miami. They, in comparison of patients that had butterfly gliomas and that had only biopsy versus biopsy and the progression-free survival actually improved to almost 3 months more, and the overall survival also increased by 6 months more, with almost no complications. So that being out there in the literature also is supportive of performing LIT for the patients. Also, the group here, as I mentioned, commented about how with giving the chemotherapy within the 1 or 2 week time frame period that I mentioned, improved the progression-free survival for these patients. So LIT and METs. So I'm showing this patient here to understand that there's different trajectories that you can access for METs, and then it depends on your indications why you're lasering this and what you can and the location and what you're trying to avoid. So you can see here that this lesion is just by the internal capsule. So the trajectory that you want to do is you're going to try to avoid hitting the internal capsule, but you also want to get actually a biopsy, and you also want to get an ablation. So this is how you're going to change your trajectory from one time to another. This is another patient that also had a prior craniotomy. So one of the major considerations that you need to understand that you need to avoid craniotomy sites, because that could lead to going through like scar tissue and dura and dural enhancements, and all of that might lead to complications, including hemorrhage that we're going to be talking about in a later phase. There's another example for trajectories for patients with bilateral occipital regrowing METs, or patient that had a unique trajectory that we went across the midline. So LIT in general can play an important role for glioma or metastatic cancer. So I think, as I mentioned earlier, having that multidisciplinary approach and going through the tumor board remains a cornerstone for the treatment of brain tumor patients with radiation necrosis. And as neurosurgeons, having the ability to judge the appropriate uses for the patient's treatment plans. LIT and PEDS tumors. So most of the reported literature choosing LIT over a craniotomy is within the adult population, more than the pediatrics. But that being said, there are people that advocate for treating lesions that are located within the deep cortical tissues that are resistant to other treatment modalities, and that we will be talking about. And then one of those lesions that have been published upon, I think, multiple series now, is the hypothalamic hamartomas. That's becoming more and more attractive in the literature. So this is also a systematic review. You can see here the number of cases in each series is pretty small, but it's out there. People advocate for it. And actually, the JNS editor's choice, Dr. Rutka's choice for the last month, this was the paper that he chose as one of the seminal papers, or one of the papers that he would recommend people to read. And it's actually looking at using LIT in PEDS patients with SIGAs. And the group at WashU, they compared their experience over 15 years with open craniotomies versus LIT. And they published their results, and you can see here those interesting figures where they show patients on the left-hand side. You can see the open resections versus the LIT, and you can see that in 14 years versus 3 years. And then they had, at the end of the day, they kind of reached the conclusion that their outcomes are very similar. That being said, it's only like they had like 15 patients in total, 9 and 7, so it's not a lot to build on, but it's out there. We can discuss as well. LIT and epilepsy. So this is the group at Texas Children's Hospital. They started commenting about kids with epilepsy and using LIT for epilepsy since the 2012. This is a 5-patient population that they've used. And then as time goes by, the group at Emory, they started commenting now about the laser for the mesial temporal lobe epilepsy. in 2014. And you can see here the laser for the amygdalohypocampotomies, and the results have been increasing. I think our institution is also now one of the institutions that performs that. So this is another case for a kid that had a mesial temporal lobe, and you can see here between the axial coronal, the axial images, the laser placement, and you can see the ablation, and you can see 1 year after the ablation. And the results are actually good in the literature with patients being in angle 1. So I'm going to talk about different epileptic focuses or different tumors. So I mentioned already the hypothalamic hamartomas being addressed by LITs. This is an insular epileptic focus being addressed by LIT. Corpus callosotomies, focal cortical dysplasias, cavernous malformations. One of the interesting uses of LIT now is coupling the LIT with the SEEG. So you can plan ahead of time that when you place your SEEGs, that you can actually, once you define your focus, that you can change that using the same burr hole to provide the patients with LIT. Moving on with the clinical indications and movement disorders. So actually, people have been performing now the thalamotomies using the LIT, pallidotomies. Latent psychiatric diseases. This has also been described in a few cases and a few case series by the people by the group in Brown University. They talk about how they've been doing capsulotomies for OCDs. Last but not least, I want to talk about LIT and spine. So I want to talk about how the group at MD Anderson are currently using LIT for spinal METs. So Dr. Tatsui, Dr. Ryans have been leading the field. I think they are the biggest group that has published on LIT as of today on spine METs. So this was their initial paper that came out in 2016. And then they talk about how it's feasible, how it's safe to in separation surgery. In comparison to an open surgery. And that was their initial paper. And then as of a couple of years now, they have compiled their first 120 cases. And they talk about their experience and they talk about what they would recommend. And I think the final, like one of the interesting recommendations that I found is how they've included now spinal LIT in their NOMS paradigm. And their indications for using the spine LIT is now that the patient has to have like their tumors between either the thoracic 2 to thoracic 12. Patient does not have any neurological or motor dysfunctions, and it's an Wilsky 1C or 1C 2 or 3, and it has to be contained by the PLL, and the patient have high risk for open surgery. I think those are all things that we can discuss, but they mentioned how it's contraindicated in cervical and lumbar. If the patient has any deficits, they should not use it. If the patient had any hardware and so forth. I found it interesting because at this time we are not performing a spine LIT. So they explained their experience. They showed how to place the patient. I think it's interesting to see how they place their fiducial markers, how they apply how they position the patient, how they prepare the patient, how they place their clamp, and this is how the patient is positioned inside the MRI. This is their steps going through how they plan their trajectory. This is placing 3 different lasers in there, and their trajectories as well. So as I mentioned, this was as of now, the main or only experience. So Dr. Bilski actually wrote an editorial on the MD Anderson group, and from his experience, that although the MD Anderson group did a great job, but it's still that the indications and the applications currently limited, and also the time and the resources that they're going to put into spine LIT are not worthwhile the investment. So that's a food for thought to discuss as well. The last thing I want to talk about is the complication and the safety profile. So some of the complications that we've seen in the literature, we have not seen any of those, luckily, at University of Miami, but we see here the misplacement of the laser fiber that does not even reach the lesion, the epidural hematomas that can develop due to inadequate dural puncture initially. And although you can see here in this case that the lasers in the hypothalamic hamartoma, and it's going to get ablated, but still the patient developed an epidural. This is the published rates of complications so far. You can see they're minimal in comparison to like open craniotomies, but there are complications that can arise. So the safety of LIT. So as I mentioned, the safety has been published in multiple publications since 2008, but there are complications that should be considered, including the hemorrhage, neurological deficits, site infection, edema, and increased seizure frequencies. All those in comparison craniotomy are minimal. This is here just a case just to show you how the laser works. So this is a patient that had multiple pullbacks that we can see here, how you can ablate a whole tumor across. And you can have multiple pullbacks and you can increase the volume of the tumor. And you can see here the different temperatures across the probe on the MRI thermometry. So this is what you see when you're ablating, when you're sitting in the MRI with the technician and as you ablate your tumor. This is a patient also you can see here that had already had a prior resection, now developed a recurrent tumor. It's by the ventricle. Patient we discussed we did not think is a good surgical candidate, so ended up being ablated. You can see here how the patient with like deep-seated tumors, insular tumors, laser is a great option. This is a patient, a female patient had this incidental finding. We discussed about like getting a biopsy and then ablating. It was a low-grade glioma. So in conclusion, LIT is an appealing option. It's minimally invasive. There's a lot of growing body of evidence now to demonstrate that LIT is effective and well tolerated. There's no one standard protocol. I've seen different attendings, even our university perform different protocols, different ways of how they perform their LITs. But I think based on what I've experienced so far being a resident here, I think the successful treatment of LIT patients depends on the neurosurgeon planning, the safety, the exposure, and the adaptive decision making with the different cases. I'm happy to take any questions and comments you guys have.
That was a great talk, Adam. In your opinion, what do you think the future of lit is here at UM? I mean, now a lot of centers are getting lit, and using in neuro-oncology. It's approved by, the FDA has its own coding now for lit that's reimbursable. So what do you think the future is, at an academic institution for something like lit?
I think that LIT is gonna like expand to different kinds of pathologies. As I mentioned, there's a lot of things that we've seen in the literature out there we're not really performing. Like for example, I've seen how they now there's a lot of literature out there about cavernomas being addressed. So I think LIT is gonna expand to include more and more pathologies that we have elected to resect in the past. I think there's more people that are going to get lit as an initial therapy for newly diagnosed lesions versus now where it's kind of mainly like palliative or mainly like as a second step or so forth. I think that's going to expand a lot in the upcoming years. And this is what literature have been showing so far.
Yeah, I completely agree. I think the other thing that I think is kind of interesting, if you look at the centers for newly diagnosed, gliomas across the country, there's probably like 6 centers that are actually offering like immunotherapy for recurrent gliomas and lit at the same time. So it's kind of interesting to see, newly diagnosed and recurrent. Yeah, so I think it's kind of interesting to see how people are using it to potentiate other therapies,
Yeah.
um,
No,
in that setting.
yeah, no, I definitely agree with you. And I think understanding like how the lit opens the blood-brain barrier, which is something that has been discussed in the GBM literature for years, and how you can make sure that the chemotherapy gets there in initial time. Our standard protocol or the STU protocol, I think has been there for too long now, that there's other things that are gonna be added. And I think lit is one of the things that are gonna be changing the field moving forward.
Great work. Thanks, Adam.
Uh, yeah, Sam, I see your comment about spinal lits. So from a UM experience, I know that we had one case of lit that was done in the past, and I believe from the experience of the people that done it there, it was painful and it was a long procedure. I think Dr. Tsutsui addresses that in his response to Dr. Bilski, that they have streamlined it, and I've heard that from different reps as well, that they are able to now do the spinal lits in under 3 hours. So I think as the experiences increase and other centers start to use it more, there's going to be like, I'm sure, like an interest from like industry. So I think at the end of the day, we will see this changing in some sort. But as of now, I agree with you. It might not be the good time for it yet.
Dr. Rajguru, are you here?
Well, while I'm just getting to the campus, I can tell you a little bit briefly about the neural engineering efforts at the university, especially at the Miami project. If any of you haven't come, I know Dr. Levy has done a great job supporting the efforts over there, along with Dr. Dietrich. We have really great new faculty, new-ish faculty. They have been here for several years, but Dr. Ganser, who's doing a very interesting work in vagal nerve stimulation using non-invasive neuromodulation. We have Dr. Kanamori, who is working on using vagal nerve stimulation for tinnitus. We have Dr. Prasad, of course, that you have heard about, who does a lot of stuff in brain computer interfaces, and Dr. Dumont, who does a lot of innovative work in biomaterials. So I hope that as you pass by Miami Project, all of you, like, you'll stop by and see the amazing work that is being done in collaboration with all the colleagues in Miami Project, the neurological surgery. I won't touch upon this today, but I also wanted to sort of highlight some of the really innovative work that is that you have heard about a little bit. Dr. Nadine Kerr talked about, like, some of the work with Alzheimer's that she's doing, and we have started to look at how hearing loss, because I have to bring the ear into everything, and not just focus on spine or the brain, but we're looking at how hearing loss and early balance dysfunction can affect long-term cognitive functions, and whether that leads to a progression of symptoms in Alzheimer's disease. So there's a lot of interesting and innovative work and collaborative, really interdisciplinary work that is being done. And I hope that you all will stop by and learn about it. And I'm just about to pull up the Miami Project, so I'll be with my PowerPoint in 2 minutes. Good morning, everybody. I hope you can see and hear me, and I'll bring up my PowerPoint. All right, everybody. I apologize that I'm a couple of minutes late. Just had a little late evening reviewing NIH grants and things like that. So today, what I'm going to talk a little bit about is work that my group has been doing at the University of Miami on applications of hypothermia in the inner ear. Maybe it's a little bit more of an update for some of the faculty colleagues who were present, like, maybe about 5 or 6 years ago when I last gave the grand rounds. But what I'm going to try to do is keep it a little bit more focused on a topic that is very important and interesting to me personally now, is how do we take our work, research that we're doing at the universities and institutions and in our labs, and really try and move it into a clinical realm to benefit patients, and what are some of the sort of, like, challenges and things that come along the way. And I'm going to try to give you my story of what that looks like. So I'm a professor in biomedical engineering and otolaryngology, and I'm also part of the Miami Project, as well as the Miami VA. And the first thing that I always like to talk about is the people within the group, people and colleagues and and friends who really make all of this really work. Without everybody that you see in these pictures over here, especially the PhD students and the postdocs and the undergraduate students and the research staff, and all the colleagues at the University of Miami, Dr. Kerr and Snap and Hoffer and Dr. Dietrich and others who make all of this really feasible and also fun to be here. Some of the colleagues over here that you see, Dr. Chalishi, a fantastic chair of a large clinical department, who not only will support when you need help in terms of understanding how a certain device or something like that is going to work in the OR, but he'll share the dessert with you too, and as well as Michael and others who work, and then of course my long-term colleague and friend Curtis King, with whom I have a startup called Restore Your Devices. So with that, I have to first give you my disclosures and let you know that I do have a startup called Restore Your Devices, and I have some intellectual property and stuff through there. I'm also part of the VA and the DoD, Department of Defense, and so whatever I say is my opinion and not that of the government. So right off the bat, I just wanted to start a little bit about how do we move from preclinical research that we do in our labs, and that can be preclinical, meaning that it could be animal research, but it could be something that we're also observing something in patients, and we're thinking about how to change a certain tool or a certain diagnostic or whatever, and think about how do we make this a broader application to benefit more patients. So if I may pose this question to you, what are some of the next steps that you would think about that we need to do? If you hit upon some discovery, you're thinking about maybe there's some clinical relevance to this thing, and so how do I, as somebody who is a resident, a fellow, a faculty member at a university, move this forward? Anybody want to help me out a little bit? No? Nobody? Well, I'll give you my version of many years ago what it was. And I thought that I'll submit a patent to the university because that's what everybody tells me to do. Start a company, go to the business school and learn some stuff about how to raise money and build pitch and stuff like that. As an engineer, I could always build a product. And then eventually everybody's going to buy it, right? That was the plan. That's what happened. And of course, living in Miami, I think about the life that you could have as a successful entrepreneur, for example, especially when every clinic and every patient is going to buy your product. But unfortunately, you learn with experience is that about 98% of the startups really end up something like this. My startup and my work that I'm doing is somewhere in between. I'm still trying to make everything work and be optimistic about it, but it really feels something like this, and this is really I'm focusing on the residents and the fellows and any trainees and early career faculty. This is not to say that it's not worth attempting. It's absolutely worth attempting. But if you do attempt something like this, right, you're going to feel like this guy who was at the edge of the stratosphere and jumped out, and there'll be probably many minutes in between, right? Where he kind of passed out, and you feel the same way. But eventually you land, and eventually, the success stories that come out of institutions like the University of Miami and Miami Project, that make it worthwhile, that make the whole journey worthwhile, because it's going to benefit a lot of patients and support them. But the pathway from a lab or a clinic or anything like that to the company is not always straightforward. There's no book, there's no linear pathway that just kind of guides you and says go this way and make these decisions and go talk to this person and it's gonna just work out and become a successful product or a company or something like that. It's really zigzag. And the only way you learn that is through experience, by going through it. So what's my story, right? In all of this, we started in about 2015, so thinking about, can we use hypothermia to preserve residual hearing in cochlear implant surgeries. This was a small pilot grant that I got from our Miami CTSI, the Clinical Translational Science Institute, and then eventually got some funding from NIH as an R21 and others. And then, started thinking about how, is this something that can really become a product? And then how do we diverge from that to build additional applications of hypothermia, especially in areas such as noise-induced hearing loss and tinnitus and noise-induced vestibular dysfunction and others. So it kind of shows you that it takes many, many years, to go from initial concepts to having something that even resembles potentially a clinical application. And it requires a lot of support. Luckily, at least in the United States, we have multiple funding agencies such as NIH and DoD and VA, who really are interested in some of these outcomes and improving those for patients. And so we get support from there to be able to do the work that we do. And I don't want to today bore you with the science of all of this stuff, but one of the challenges in cochlear implant surgeries, and I'm sure that some of you have been in ORs with one of our neurologists, perhaps probably more focused on the auditory brainstem implant rather than a cochlear implantation, but we have multiple surgical suites in Ablay as well as in Jackson where they do cochlear implant surgeries. And one of the challenges in the CI surgeries is that when you introduce the electrode through the round window of the cochlea, the surgeon is kind of blind to this. So these are some CT images of the electrode or sorry, I think micro CT or something like that, from quite a while ago, showing a cochlear implant array being inserted. And what you see over here is that as the physician, as a surgeon neurologist is introducing it, they're hitting some of the sensitive neural structures. They retract the electrode, they push it a little bit further, but as the spiral bends and the electrode bends with it, you're hitting both the walls and causing significant amount of trauma. And ideally what you want is something like this, something, an electrode that is very nicely hugging the neural structure so that you can have hopefully a high fidelity neuromodulation and a sound perception. But what happens is as you cause this trauma, these mechanical injuries, there is significant damage to the underlying neural structures. And we know a lot about all of these mechanisms, but nothing in the field has really come out in terms of, or at least at that time, about in 2015. And so about what could potentially reduce some of this trauma. And we think about a group of patients that is between the patients who get hearing aids and patients who are eligible for cochlear implantation. As you might know, there's a lot of people who get hearing aids who do not benefit from it any longer because they have a low amount of sort of low frequency residual hearing. And majority of their high frequencies, they're fairly deaf. But according to the FDA guidelines, these patients are not eligible for a cochlear implantation. So what was done was to create these new electroacoustic stimulation devices, which are hybrid devices, and they use two modes. So they use a short electrode array to give electrical stimulation for the high frequency regions. And then you use a hearing aid to kind of provide that second mode of stimulation for the low frequencies where the patient has some hearing. Unfortunately, in these patients, there's a very high incidence of residual hearing loss at the low frequency. So now you're putting an electrode that is supposed to allow a bimodal stimulation and perhaps more natural kind of stimulation of the cochlea. But the insertion trauma itself causes significant damage. So we started thinking about could you build in the lab a little device and deliver cooling just to the cochlea, because again, you're not going to cool the whole patient for a cochlear implant surgery, unlike you might do for a spinal cord injury and others. And being engineers, we figured out a little system that allows us to circulate very cold liquid through this little probe. And that metal probe that cools down can be placed right next to the cochlea to reduce its temperature. And with this little system that we built, like, right here in the lab, we went out and we looked at some animal studies, and we looked at, like, the black line here is baseline hearing of all the animals. And if you look on the y-axis over here, what you're seeing is that the higher the number, the louder the sound or the stimulus that is needed to hear. And the red curve is animals that are getting a cochlear implantation. And what you see is that starting with day one, there's a significant residual hearing loss across, like, the frequencies. And this is just showing you one frequency, but essentially across all frequencies, we saw the same thing. But if you treated them with hypothermia at the time of surgery, so on this day one, when we inserted the cochlear implantation, if you cool them, you would see a protection and eventually a recovery of that residual hearing in those animals. So that was sort of, like, exciting for us. And we said, okay, like, there might be something there. We did a lot of immunohistochemistry to show that, like, hair cells are protected as well. So this is an implanted cochlea, and this is an implanted cochlea that was treated with hypothermia. And you can see how it looks compared to the control cochlea that was not implanted. But we started thinking about, like, immediately, like, what are some of the data sets that we would generate, right? Like, not just for a publication, but thinking about, like, is this an application that eventually can move towards the clinic? So, of course, we wanted to expand the number of days and look at whether, like, one-time application of hypothermia is protective in the long term. And it seems to be protective. We wanted to look at, like, whether the hair cells and the structures are rescued, and it seems to be protective. And whether the cooling itself is safe. So if you were to cool the cochlea compared to non-cooled cochlea without doing any kind of electrode insertion, would that affect any kind of hearing function, right? And at least at the mild hypothermia level, right? Like, we didn't really see any damage within the cochlea or residual hearing issues. So these are the kind of, like, data sets that essentially FDA and the regulatory agencies, as well as, like, as a researcher, as a clinician, you want to look at and make sure that this is something, an application that's going to work before you move to a clinical application. And of course, being researchers, we're interested in, like, using the newest tools and the newest scientific methods to probe mechanisms and stuff like that. So we did a lot of work on mechanisms of hypothermia, and I'm not going to bore you with all of this scientific data, but suffice it to say that we're learning so much about, like, what are some of the mechanisms that hypothermia could be preventing. And for example, like, Dr. Sangalletti in our lab working with Dr. Kerr, and really, like, through a lot of help that they provided us, we looked at, like, very early sort of pathways called, like, pyroptosis. And now we know that gets activated, and that leads to, like, activation of caspases. And through Dr. Dietrich's work, we know that hypothermia is actually protective in pyroptosis. And so we're working on that. And then now people in the group are actually thinking about how do you take hypothermia at one time point and combine it with a second, potentially a synergistic or even an additive pharmaceutical therapy that can come in at a later point of time or at a different point of time to mitigate other mechanisms and provide, like, greater protection. And that's some exciting stuff that we're doing that hopefully, like, I'll talk about in a couple of years if you invite me again. But as I said, like, the thing that I wanted to focus on is, like, how do we bring these things to market? And again, as we have the preclinical models, we showed the efficacy, we showed the safety, we showed that this is feasible. We then started thinking about, like, how would we move this into a patient group? And of course, the first patient groups that we had is in the King's lab, in the Rosenstiel building, which is the cadaver heads. And we imaged a bunch of these cadaver heads and created numerical models, like, finite element models to look at, like, can we actually cool the cochlea, and how much cooling will it take to actually reduce the temperature down by about, like, 4 to 5 degrees, right? And we can look at that in female heads versus male heads, which are, of course, like, much larger and thicker bones and things like that, to make sure that we can continue to deliver, like, sufficient cooling that's going to have a meaningful therapeutic effect. So we've done a lot of this work, and again, FDA looks very carefully at a lot of these things that you are giving them. And as engineers, we build systems that look better and better, hopefully, right? So this is the very first system that one of my early PhD students, Ilmar Tamam, is and I made. And we keep it around for historic purposes. Someday maybe there'll be a museum of therapeutic hypothermia devices in the Miami project on the first floor, and maybe this device can go in there. This was our really version 1 and then version 2 that we have built, and this is what the new system really looks like. This is what the system that we have now prepared for the clinic really looks like. And the idea is that you have a disposable device that comes pre-filled with a cooling system, and then the device essentially attaches to this, and through a very small panel in the front, you can start delivering hypothermia as soon as you are ready with the patient in a surgery. And our application of how we give hypothermia has also changed. We used to initially put the probe right next to the bone on the promontory of the cochlea. Of course, that creates surgical challenges and others. So we moved it now to the ear canal. And what we do is we circulate cold liquid essentially through a probe that sits in the ear canal to through heat convection cool down the cochlea. And this is what it really looks like. So we have this this balloon catheter device that essentially pops and is filled with cold saline once this device starts cooling. And provides therapeutic hypothermia for the duration of the surgery that we have, and we call it research. One of the fun things that you get to do as an inventor is try and think about what are some of the cool things that you can make. And I came up with restoring ear, and so restore ear devices, and then came up with research as a restore ear surgical device as a name. And it just shows you how the device works. You might recognize that wall in the back. So this was right here in the Miami project building where we took that video. And it takes a lot of evolution. So this was our first probes in 2015, 2016 to multiple designs to this is where we are now in 2023, 2024. So it's taken us 7-8 years to come to a level where we are ready for the clinic. And one of the really great pieces of news that we got just last week from the FDA is that the FDA essentially classified this device as a no surgical risk, meaning that for a clinical trial at the university that we have now funded through a phase 2 SBIR grant, does not require us to do any additional IND applications or anything like that. So we can essentially start the clinical trial once the IRB is approved. So then that brings us to the next phase of where all of this evolves, right? And that is to really think about where can we do where and how do we do a solid clinical trial to tell us, give us the confidence, give the field confidence that this is a potential application that can benefit patients in their own clinics. And so we, again, very, very fortunate that at University of Miami, started by Tom Balcony and colleagues, very early on in the 1990s, we've been leading the field in the number of cochlear implantation and the surgical processes. And in 2023, this is half the year. So once you look at the full year, we're going to be about 220 electrodes. Cochlear implant surgeries that have been placed in our otolaryngology department here, which is great. So there's a great pool of patients that we can recruit from, and we can study this. And again, we have a division of audiology that allows us to work with it. And this is a really great partnership between a startup, Restore Ear Devices, that got a phase 2 SBIR grant from NIH to do a clinical study along with the University of Miami. So now everybody is hopefully benefiting from this. And one of the in a twist of fate, actually NIH also made a decision to, in parallel, fund an R01 in my lab so that we have two parallel studies going on. Through the R01 mechanism, we're doing a lot of preclinical studies for 5 years. And through the SBIR mechanism, over the same 5 years, in parallel, essentially, we're doing all of the clinical work. And one of the thoughts that they have is that this might be a model that NIH uses in the future to support more of translation from and early translation from preclinical to the clinical side. But we are about to submit the IRB on this, and the idea is that we'll have two aims. One is just to show safety, and this is going to be a very small study with 6 patients. We're going to be device agnostic, and the whole point is to show that if we cool the ears of these patients down, that they have no loss of residual hearing, but also that the cochlear implant device just continues to function. So we don't really need patients who have residual hearing for the safety study, but this is just to show that everything works, that in the OR, everything is okay, the patients are alive and kicking afterwards, and that the cochlear implant device itself is not affected negatively. And then on the other hand, we'll do a safety study, efficacy study afterwards, where we'll have 2 groups of 24 patients. One will undergo cochlear implantation with the hypothermia, just as we did in the preclinical studies, and the other group will get a standard of care treatment, which is delivery of intratympanic steroids, et cetera. That is standard within the clinical realm. So we're just going to have two arms of this study, and again, as an engineer, as a scientist. One of the really great things that I have benefited from is really the interdisciplinary nature of the team that we've been able to build. And we have really excellent, audiologists, Dr. Snap and Dr. Prentice, who are going to be helping with this. And they work with us to understand, what are some of the parameters, what are some of the measurements that we want to show that are clinically relevant and clinically meaningful in these. So with that part of my story, right? 8 years later, where we are, is that we're doing a lot of preclinical studies. We're looking at some very innovative, combination therapies. Maria in the lab is Dr. Yepes, I should say, is in the lab is looking at that. Kayla Meinsinger, who is a PhD student, is also looking at some innovative work, what happens with veterans and people who have prior histories of noise exposure, and how do they benefit from cochlear implantation. But now we're about to begin clinical trials at the University of Miami. So wish us luck with these trials and the next steps. And then I'm going to pivot to what happens, right? So you have this one product, one surgical device that we created, and that's great. But one of the things that you realize very quickly on in the field of startups and medical devices and therapeutics and others is that it takes a lot of time, it takes a lot of funding, it takes a lot of money and patience and hard work to get there. But that's not enough, right? You have to kind of be inventing and thinking about other areas that we can do. And luckily for us, just around the time that we had shown safety and efficacy of hypothermia for cochlear implant surgeries, a lot of work had begun to come out looking at how recreational and occupational noise, hazardous noise, affects hearing. And in fact, there are estimates that 25% of adults and now close to 20% of teenagers, just from going to concerts and being exposed to damaging noises in their environments, can have noise-induced hearing loss. There is an estimate that now about 1.3 billion people in the world suffer from this problem, and many of you might have experienced a little bit of this, and I won't bore you with some of the pathologies and stuff like that and what goes on. But one thing that I always like to point out is there was work by Sharon Kujawa and Charlie Lieberman at Harvard that shows that if you expose animals to rock concert type noise for 1 hour or 2 hours, and if you look at the inner hair cells and all of the synaptic connections that are formed on the inner hair cells that you can see on the left in the cartoon, And on the right, if you look at like, what they look like in a control cochlea, and you can see a lot of synaptic ribbons, these little red dots all over. But if you give them a noise exposure that's just enough about like in a rock concert, what you see is that a lot of those synaptic ribbons and the contacts on the hair cells have disappeared. And you might have experienced some of this, like, when you go to a concert or when you go to a loud a club or things like that, or when exposed to a lot of like, drilling noises, etc. In the evening or at the nighttime, like, you might get some of that silencing or ringing in your ears, and maybe the sounds here are a little bit muffled. By day one or day two, like, everything seems to be normal. But what they then showed is that this early sort of like, loss, where the synapses actually retract and then eventually come back after some time, and some of them come back in the right spot, many of them don't come back in the right spot, that actually leads to exaggerated loss of spiral ganglion neurons and the cell bodies in those animals. So just one-time noise exposure can be significantly damaging in the long term. And in humans, that's not going to show up for like 30 to 40 years. And so we started looking at that. As I mentioned, like, we have a really interesting study that we're doing with Dr. Nadine Prayer, looking at how noise-induced hearing loss actually affects Alzheimer's disease and progression of Alzheimer's disease. And we have some very early, exciting and interesting results. I shouldn't say exciting, but really interesting results that show that there is a significant change in animals who are predisposed to Alzheimer's with hearing loss early on. And we're starting to understand a lot about some of the mechanisms and stuff too. And this has been shown now we're showing it in animal model, but this has now been also like, being shown in human studies. We're looking at patients who have Alzheimer's or dementia or similar neurocognitive decline, that there is a significant exacerbation of neuropathologies related to that from hearing loss early on. So again, like, I started to think about like, where we would go with all of this. And one of the first things that you want to show is that this is really this type of a damage that Sharon and Charlie showed in an animal model is really happening also in people. And one of the nice things that we were able to do with working with our audiology colleagues, as well as colleagues from School of Medicine, so you see Natasha Soul over there, with one of the firefighters, is to partner with fire stations across South Florida. And we started to look at like, 400 and now 40 firefighters, very young age, like, median age of like, 38, and look at whether during different times of their service, are there changes related to their hearing and balance function from the chronic noise exposure in their services that they have. One of the first things that, again, like, I did was I gave them Apple Watches to wear. And if you notice that, your Apple Watch will tell you when things are really, really loud, and it asks you to like, move away. Most of us probably just silence that notification and continue to be where we are. But in the firefighters, if you look at a 24-hour service, so firefighters work for a full 24 hours, typically from 7 a.m. in the morning to the next day, 7 a.m. They live at the fire station. And if you look at the equivalent exposure in decibels, it were 8 hours, but this is really a 24-hour shift. We've just compressed it down to show you. If you look at firefighters versus people who are non-firefighters, yes, they go to like, loud events and things like that, and restaurants and others that in some cases produce like, higher decibel levels and noise exposures. But on average, the firefighters are typically 12 to 15 decibels above. And then in many of them, like, if you look at the equivalent time of exposure, the control subjects, all of us, like, we might get to like 20, 30, sometimes a couple of hours of exposure at a music event or when you go to a football game or something like that. But firefighters get anything from a couple of hours to 14 to 15 hours of these noise exposures. So they have a very significant incidence of loud noise. And working with my colleague, we went out and we did like, measurements of audiometry and others related to hearing and balance functions. as well as mobility and gait. And just one example to kind of show you, if you look at the auditory brainstem responses of control subjects, these blue lines, versus the firefighters, the red line, and if you look at them just at 1 year, within 1 year of service, so these are very young candidates who are typically 20 to 22 years of age, and they have just joined the fire service. Within that first year, you already start to see morphological changes that are happening in their auditory responses. And then that gets exaggerated by the time you are in mid-career versus late career. And look at the late career, there's such significant changes that they have, and many of them are, in fact, like, wearing hearing aids at that time. And you might think that late career is somebody who is 70, 75 years of age, but in the firefighters, remember I told you that they started about 20 years of age. So these are typically 45 to 50 years of age firefighters who already have significant hearing and balance deficits. So that accumulated noise exposure that they have is leading to a significant damage in them. And so we started thinking in our lab, like, can we actually cool the cochlea by creating a little neck collar for these rats and delivering non-invasive cooling and looking at, like, what happens in them. And of course, like, we measured the temperatures, and we could actually cool down the cochlea through this approach. Without boring you too much about the science, what we see is that if you expose them to a noise that is just like rock concert, going to rock concert for 2 hours or a music event for 2 hours, you see this huge elevation in thresholds at day 1 after noise in 2 groups of animals that get no treatment whatsoever. But the treatment that the animal group that got treated, you see that there is a significant recovery already on day 1 of those hearing thresholds. And by the day 3, day 7, those thresholds are recovering very close to what their baseline originally was. And it continues to be that way. And so we were very excited at the time, like, with this data. And we thought, like, would it also prevent that synaptic loss that we had seen? And lo and behold, like, if you look at this measurement of this amplitude of those ABR waveforms that I was showing you, so imagine this is a control subject and this is a firefighter, or this is a control animal, and the orange-red curve is actually an animal that got exposed to the rock concert noise. If you look at them just day 1 post-noise, what you see is that the amplitudes are actually really well preserved in the hypothermia group versus in the noise-exposed group. And those amplitudes in the noise-exposed group don't really recover even a month later. And not just that, like, if you look at those like, paired synapses, and so, like, if you just look on this right side, what you see is that in the noise exposed group, like, those synaptic elements are not only fewer, but they're actually unpaired, meaning that they don't pair with their presynaptic receptors, versus in the hypothermia group, they're always pretty much paired except for a few of them. So we're, again, like, very excited by these results. We just published all of this in some of the leading journals to kind of show that this effect not only is true in one group of animals, but in multiple groups of animals. It protects actually those spiral ganglion neurons as well. And that one-time cooling after the noise exposure that you have continues to protect for up to 12 months, right? Like, so this is really exciting stuff. And so again, how do we take a discovery that you made like that and move it into a clinic? And so, with my, again, ability to come up with names, however silly names they may be, I came up with a name called Rebound, meaning that we're going to rebound the hearing after a noise or a traumatic event or something like that. And we created essentially headsets that have cooling gel pads that go on your mastoid, and through that deliver cooling to the cochlea. So these are, like, some numerical models, finite element models, using our devices in whole human heads. And you can see, like, how within, like, 20 minutes or so you can cool down the cochlea. And so now we have created a series of devices that, in fact, are on market now. Also, no significant risk. So we can now, like, deliver cooling to patients as well as to firefighters and others. And we're starting another clinical study with firefighters going in after their 24 hours service is over and providing cooling and looking at through these devices called Rebound and Rebound RX and look at whether that benefits hearing, just not in the acute term, but even over 1 year follow-up periods. So where are we today with that? Again, very fortunate that we have funding to look at all of this in different kinds of animal models and look at combination therapies and things like that. But in 2024, with SBIR phase 2 that just got a really excellent score as well. We're hoping to start human studies and eventually start thinking about are there other applications like tinnitus and others where we can move forward as well. Again, none of this would be feasible, and I always like to close back again, with the people that make it feasible. None of this would be feasible without everybody in the lab, everybody outside of the lab, everybody in the clinic that are contributing to the projects that we have in the lab, and really bringing very innovative ideas. One person could never do all of these things alone. And then having colleagues who you call up and you say hey, you have this Alzheimer's model, I have this really crazy idea of exposing them to noise and blast and looking at whether something happens with them in terms of Alzheimer's outcome. Would you look at it? And your friend picks up the call and says, yeah, sure, I'll help you with that. And so you have really great colleagues and friends who entertain some of your ideas and work with you, and that's what really makes all of this feasible. Again, the story is not complete yet, right? We're continuing to work on all of these things. And if you invite me back again in a few years, I can give you an update of where we are with some of our clinical trials and studies. But with that, I'll open up and ask you if you have any questions or discussion or comments or anything that I didn't explain well. I'm happy to explain.
This is Ashish Shah. Nice talk. Very impressed to see you kind of take a model from kind of preclinical to kind of clinical trials and SBIR grant. Just out of I guess feasibility, how long do you leave this guy? I think in cochlear surgery they're pretty quick. So how long are, I mean, quick, I guess relative to neurosurgery, but how long do you leave these catheters in in the ear, and what target temperatures do you get locally with your device?
Right. Yeah. So that's a great question. So for the cochlear implant surgeries, initially our target was through the devices that went through the facial recess and really connected directly with the promontory. We were able to provide cooling directly to the cochlea, so we could do it fairly fast and fairly quickly, right? And perhaps much more control than we can with the ear canal. But the goal was that we would have about 40-minute duration of mild therapeutic hypothermia during the surgery period. Now, with the external balloon catheter design that we have, what we're working on is that as soon as the patient is sedated and ready for prep, the surgeon can slide the balloon catheter and start cooling the patient. And there is no reason to take out the probe until after the surgery is complete, because it's going to be outside of essentially the surgical field, because you're going behind the ear on the mastoid and drilling and doing the surgery. So the ear canal is just going to be sort of draped over with the balloon catheter in there. We've done a lot of studies, Maria in the lab, has been working with Restore Ear devices and looking at whether the numerical studies that we've done and the clinical studies in the temporal bones and the cadaver heads match up. And what we see is that we can get to about 3 to 4 degrees temperature drop, which is really good for mild therapeutic hypothermia. Within 20 minutes or so, and we can maintain that for the duration of the surgery. And the other thing that we're also sort of like, looking into is whether these external head cooling devices can be something that any patient who is undergoing any surgery that has a risk of hearing can take with them when they leave the hospital, and actually for a number of days, like do cooling afterwards.
And so the intraoperative cool. So thanks, that's a great answer. So the intraoperative cooling basically provides, enough neuroprotection for to mitigate the secondary injury, I'm guessing.
Correct.
From the trauma of surgery.
Right. So, I think, all of the preclinical work points towards that. That application, which is going to be really sort of peri-operative and during the surgery itself, right? Rather than multiple hours or many days after the trauma has occurred, we're delivering cooling right at the time of when that injury is happening, and that's going to provide a significant benefit.
And I'm guessing you've already talked to some of the other Dr. Dietrich and everything about kind of using the same modality for spine and kind of post-operative neuroprotection locally for spine, because the systemic hypothermia has its challenges for a variety of reasons. So I mean, I think the local delivery and your device seems very applicable, not just for cochlear but for a lot of other applications, I imagine.
Yeah. One of the studies that we have with Abhishek Prasad is looking at cortical electrodes that are implanted in the motor cortex, right? For neuromodulation in patients, and even that insertion of that electrode and the wires. Even when you think about the Neuralink micro wires and stuff like that, that insertion itself can cause trauma. And so we actually looked at whether we can regionally just cool down the cortex, around the electrode, and that seems to be actually protective in terms of all of the mechanisms as well. And certainly, we have talked with Dr. Dietrich about how this might expand to spinal cord injury. If there are anybody in the group that is interested in collaborating and working on that. Not that I can take on more projects. I know people in my lab are probably cursing at me right now that I even mention it. But I would be happy to collaborate and think about how such a device can really go in the clinic and do and support any kind of experimental studies and things like that. So absolutely, we've spoken with Dr. Dietrich, and I'm happy to speak more and discuss new ideas.
Yeah, I think that's amazing. I mean, and some of our colleagues definitely would probably be interested in a potential collaboration. So great talk. Thanks again.
Yeah, thank you very much. I guess I know time is a great gift to give to anybody. And so it's good that I finished a little bit early and you have 20 minutes of your time that's free to you. So I can stay on if there are any questions and stuff like that, but I appreciate all of you, and thank you again for listening in.